Elliot, you might want to take your slides off, share. So I think we're ready to get started.
Perfect. Good afternoon, everyone, and welcome to today's webinar. My name is Chelsea Townsend, and I'm the director of the South Carolina Prescription Monitoring Program, and I also chair the NASCA Education Committee. I'll be hosting this afternoon's webinar along with NASCA's Kathy Keogh. Hopefully you've read the scrolling material while waiting for the webinar to start, which provides information regarding our sponsors, a NASCA disclaimer, housekeeping items, and announcements. Just a reminder, the travel scholarships for this year's annual conference are open until next Friday. We encourage people to apply for those. Please make sure you take a peek at that. Also, NASCA has officially launched their social media, so please be sure to follow them on Facebook, Instagram, LinkedIn, and X. The preliminary 2025 conference schedule is now on the website, so you can go ahead and start to register for this year's annual conference now. And then hotel booking is also open online. One of the important things from today is this webinar will not be recorded today, so please make sure that you pay attention and get all the information from the webinar. It will not be available after the webinar. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. So thank you to our sponsors. And thank you for taking your time out of the day to join us for today's webinar on an insider's view on Washington, D.C., an overview for state policymakers, controlled substances authorities, and prescription monitoring programs. We're really excited today to have Elliot Weiss and Nisha Quasba with us today. So please allow me to introduce them. Elliot Weiss is a director of health policy and government relations at Faegre Drinker Consulting. Elliot has an extensive background in controlled substance policy and focuses on the nexus of federal and state government regulation of healthcare. Before joining Faegre Drinker, Elliot served as government affairs director for the National Council of State Boards of Nursing, managing their legislative and regulatory outreach in Washington, D.C., and providing expertise on issues related to nursing workforce, APR and scope of practice, and interstate license portability. In that capacity, he served on the American Telemedicine Association's Policy Council and the steering committee of the Nursing Community Coalition. He also has insight into the inner workings of Capitol Hill from his time on the legislative and executive staffs of former Senator Evan Bayh. Nisha Quasba is a seasoned government and regulatory affairs professional at Faegre Drinker Consulting with a proven track record of navigating the legislative landscape to drive meaningful policy reforms. Through her advocacy, she has successfully built bipartisan, bicameral support for critical legislation, shaping policies that resonate with diverse stakeholders. Her work has made a significant impact on the rare disease community, the telehealth sector, and the practice of pharmacy. A dedicated public health policy advocate, Nisha is committed to safeguarding public health and safety through informed policymaking. Before joining Faegre Drinkers, she served as a public policy specialist with the Association of Public Health Laboratories, where she facilitated collaboration between government agencies, policymakers, and association members to advance key public health initiatives. So, welcome, Elliot and Nisha. The floor is yours.
Thank you so much, Chelsea. Really appreciate the opportunity. And while Elliot brings up the slides, one welcome you all. Nisha Quasba, as Chelsea mentioned, both Elliot and I are based in Washington, D.C. Our day-to-day is working on healthcare, but specifically offering government affairs services to our clients. And so really looking forward to today's discussion to give you kind of the inside scoop of what we're hearing here in Washington. So next slide. And what better way to kick off, just kind of level setting what has been happening in Washington, D.C. Next slide. We are now 136 days into the new administration, Congress, just about 4.5 months in, and the pace of change has been quite striking. We'll stay on this slide for quite a bit of time. What we have seen so far from the start, we've witnessed a strong hand by the executive branch, particularly in its influence over economic policy and legislative activity. The result has been a remarkable level of change, both in tone and in action, which has created a sense of real and perceived uncertainty across sectors. Since January 20th, once President Trump assumed his presidency and was inaugurated into the White House, there was no time that was wasted, and we saw an issuance of a series of executive orders in a furious manner, I would say. On day one, the president signed an order designating certain foreign drug cartels as terrorist organizations. This move provides new tools to combat illicit drug trafficking, especially of substances like fentanyl, and we'll see that trend and that as being a huge priority, fentanyl being a huge priority for this administration. But creating that executive order specifically expand law enforcement and foreign policy powers. In April, so that was in January, in April, we saw a new order targeted elimination of regulatory barriers that hinder domestic manufacturing of prescription drugs, including controlled substances. It directs FDA to streamline approvals of US-made pharmaceuticals and their facilities, and to increase oversight of foreign producers. And probably the most recent of the three was following President Trump's February executive order to reduce the federal workforce. HHS the following month announced a major transformation across the Department of Health and Human Services at the federal level, laying off over 10,000 employees, combined with earlier rounds of cuts and voluntary departures. This marks about a quarter of a reduction in the department's workforce across the board. We'll talk about what that restructuring really looks like when we're talking about NASCSA and some other pieces a bit later. In addition to those executive orders, we also saw the establishment of the Administration for a Healthy America. So AHA, this is an office that consolidates 5 agencies, including NASCSA, into one single entity, with a huge focus on chronic care and disease prevention, guided by what is considered a framework, the MAHA framework, the Make America Healthy Again framework. And the last order of business that I think is relevant for this group to know is establishment of the MAHA Commission. The MAHA Commission was established in February, chaired by HHS Secretary Robert F. Kennedy Jr. This commission is specifically tasked with tackling foundational health issues and is supposed to be issuing a report within its first 100 days. A lot of focus on reforming the food supply chain, overhauling prescription drug approval processes, reevaluating immunization policies, and a big focus specifically on children's care, with an initial splash of work supposed to be really focused on children's health specifically. But the administration's focus, as you probably also know if you're following the headlines, go way beyond just executive orders or even just healthcare generally. There's a clear and ongoing attempt to streamline the federal government with the stated goal of reducing redundancy and increasing efficiencies. However, we have seen, some downstream effects of that. meaning we're seeing grants and programs paused or terminated, particularly those seen as misaligned with the administration's priorities. A general shrinkage of government typically disproportionately impacts healthcare sector, which does represent a significant share of the federal budget, and is often a target of just cost-cutting measures and reform. So that's not super surprising. We knew that coming in to 2025, but we have seen that being executed. And healthcare is certainly not the only issue that's on the table. There's been major shifts in trade policy, including tariff changes, along with immigration enforcement and foreign policy realignment. And so there's been a lot of changes especially in the executive branch. But we've seen similarly, a change of dynamic on the congressional side. We did have a new 119th Congress, ushered in a number of new freshman members in both House and Senate. I would say historically, the Republican Party, especially on the House side, has not shown the level of unity that they have since January of this year. There's usually been this kind of thought that there's usually always some fragment of the House GOP that tries to stifle legislation's advancement, but we haven't seen that quite a bit. So definitely change in legislative action and vigor this go around. A lot of wielding of power from the White House, so a top-down approach being kind of the theme of at least these first 4.5 months. And last thing I'll say is on the Senate side, there were a lot of legislative activities, but one thing that took up a good chunk of the Senate's calendar was advancing President Trump's nominees. And we'll talk about one nominee in particular, the DEA one, shortly in a bit. But all his cabinets, so the 15 cabinet members, were advanced out quite expeditiously, as Senate Majority Leader Thune had promised the president. So a lot of change, a lot of uncertainty, but we can go to the next slide. So in April, the Trump administration released its drug policy priorities. It's actually a required annual preview of the full national drug control strategy that must be submitted to Congress. The 6 priorities take, I would say, a theme of the following. And you can see the 6 that are listed there. You can even Google it and find the full report. But I would say the first is law and order is back at the center of drug policy, meaning Trump administration is really leaning into broader border security, aggressive law enforcement and punishment for traffickers. It marks a shift, generally speaking, from a public health forward approach to one that targets cartels like terrorist organizations, going back to that executive order I talked about that was passed and announced on the first day of Trump in office. And he uses a lot of economic sanctions to pressure source countries. That would be one. So law enforcement being more the center. The second piece is leveraging technology for these efforts. So once you look at the plan, it includes AI, surveillance, military-like coordination to choke off a lot of the drug supply chain of the bad actors. Third, you'll see a theme also of fentanyl. Fentanyl is the #1 priority, reducing overdose deaths, especially from fentanyl. And the strategy also calls for expanded naloxone access, but also severe criminal penalties for dealers tied to overdose deaths. The other 2 pieces I would say are trend is prevention, which you'll see in #4. The administration plans to saturate media channels with anti-drug messages, especially for the youth, while holding local governments accountable for failing to prevent drug spread. And the last theme I would say is treatment and recovery. So support for evidence-based treatment, including medications for opioid use disorder, is there, but always framed alongside policing and public safety. So I think in a nutshell, the administration is waging a global fight on illicit drugs, especially on fentanyl, using the full force of US intelligence, diplomacy, and law enforcement to do so, with a less emphasis on public health or more crackdowns and definitely more consequences and control. Next slide. To get a bit more granular, I know I talked about general cuts, workforce cuts, and programmatic cuts, but to get a bit granular, so one is, as I mentioned, SAMHSA was absorbed into AHA, the Administration for a Healthy America, While the intention of this restructure is generally in the theme of streamlining services, reducing redundancy or waste, it has raised concerns generally with stakeholders about the potential weakening of specialized programs focused on substance use disorder and mental health. These concerns are really compounded because SAMHSA has also seen a reduction of their workforce. I think roughly 50%, impacting a wide range of their programs and services. And so seeing how that actually plays out once we think about FY26, we're in FY25 living it, that's something that we'll all be monitoring. A couple other pieces, even though in the drug policy priorities of the administration, there's a lot of emphasis on prevention and naloxone access, we did see some significant elimination, about $56 million annual grant program that supports naloxone distribution and training for first responders. So a little bit of a contrast to their priorities, but did want to flag that as one of the items that was on the chopping blocks. Couple other pieces, not so surprising, as I mentioned before, shift toward enforcement, a departure from public health. A lot of the data collection services that the federal government provides also has been cut at its knees because of a lot of those layoffs I talked about earlier, those 10,000 layoffs across HHS that impacted a number of different agencies, NIH, CDC, and others. And then lastly, a removal of online resources. So I think a number of pages on SAMHSA have been removed. A lot of them are important helplines and disaster response. So I think these are some of the reductions we've seen that are very pertinent to the work that we do that we wanted to mention. Next slide. And I just wanted to answer kind of the question that I think we see a lot in the news, and this is kind of the DC narrative, is that a lot of questions have come up about whether the president can cut programs that have already been authorized or funded by Congress. Historically, Congress has taken its power of the purse, I'm sure you've heard that phrase quite frequently used, very seriously, and has exercised what we call independent judgment when crafting actual spending legislation. Typically, the president's budget, where a lot of these cuts have been outlined, which President Trump did actually release his skinny budget not so long ago, is usually treated more of a guidance document than a binding plan. And in most cases, many proposals in the president's budget are not adopted wholly. But this time is definitely quite different. We are in what's called a trifecta government, meaning the White House, the House, and the Senate are all have the hold of the Republican Party. And so it's just a bit easier to actually move ahead with the president's priorities and vision. So we see that the president's wish list of priorities is gaining real traction. And many of these proposals are now on track to be implemented in some form or another. The shift has raised new questions about the balance of power between Congress and the executive branch. We won't get super deep into it, but a lot of the cuts we do foresee actually coming to fruition in FY26. It's just a matter of what and to the amount. But do want to also say, as a caveat to all that, there is still a lot of congressional bipartisan bicameral support for a lot of the programs that you all care about as well. So I don't want to assume that everything's off the table. There's certainly a lot of support for substance use disorder treatments, for prevention, which is outlined in the president's drug policy plan. Next slide. And we'll go into DEA updates. So the DEA, just like all the other agencies of the federal government, we're going and still is going through what I would consider like a moment of transition. The nominated administrator, Terrence Cole, has a deeply rooted law enforcement background, which you can see on the slide. He spent 22 years at DEA, where he held several senior operational roles before serving as the Secretary of Public Safety and Homeland Security for the Commonwealth of Virginia. So where he is right now, he's awaiting confirmation. The agency is effectively what we call in a holding pattern, so anticipating his arrival to take on new policy directions. And really, once the administrator is actually in office, there's a lot more direction that the agency can take. So definitely see them as being in a pause right now. But we'll go to the next slide to get a little bit about, what are his thoughts, his views, his beliefs And we can look to the way that nominations typically run is that there is the nominee comes before a Senate committee and there's a hearing. And so this hearing was at the end of April. And there, through several lines of questioning from various members of the Senate Judiciary Committee, I think there are certain themes we heard from him that really align him with the administration, what we heard so far. And you see that on just bullet number 1. He stated his number 1 priority is combating the fentanyl epidemic with urgency and resolve, very similar to the administration. Emphasized the cartel's role in poisoning U.S. communities, using that word specifically, called the crisis a national security emergency, blamed China for providing fentanyl precursors and being complicit through inaction. Also supports using all federal tools, including financial sanctions, diplomacy, and law enforcement, to really clamp down on the flow of illicit drugs to the United States. He does back that executive order that designated cartels as foreign terrorist organizations, so FTOs. And then some of the other pieces is, he was asked about, what are your thoughts, about what he thinks about marijuana rescheduling. He actually took a pretty non-committal stance on that one. When asked about, should there be immigration enforcement being used for combating illicit drugs, a little bit non-committal there. I think what his neutral stance on some of these lines of questions suggests he may avoid clashing with the Trump administration, possibly signaling an alignment, at least, with the administration's direction that they want to take, which makes a lot of sense. He'll be assuming the role of the highest level of law enforcement in the nation. And so not super surprising that he, emphasized not being super committal, but really aligning with what the administration has been supportive of so far. Next slide. Moving a little bit more into DEA policy. So now that we've established the current political backdrop, I want to transition to, into a pressing policy challenge, which is the remote prescribing and the online availability of controlled substances. The internet, not surprisingly, has significantly changed how people access medications. And in many cases, it's created a dangerous and largely unregulated marketplace for controlled substances. And some of the key data points that we share frequently are listed here. And I'll only name a couple of them. You can probably read the rest. But in 2023, 96 million prescriptions were filled through illegal online pharmacies. And that was a 47% jump since 2019. Of the 40,000 illicit drug outlets identified by the National Association of Boards of Pharmacy, over half offer controlled substances, obviously, often without requiring a prescription. So certainly concerning statistics. Next slide. So while while the access to these illegal sources is truly concerning, we need to recognize that there has been a shift in the consumer landscape, meaning Americans are increasingly comfortable using telemedicine and online pharmacies, even for sensitive prescriptions like controlled substances. And we have some consumer behavior survey data that is listed out here, where we found that 54% of Americans have previously purchased medications from an online pharmacy for themselves. 66% of Americans would likely purchase medication that is unavailable at their local brick and mortar pharmacy. We're thinking more of those that either are restricted because of a drug shortage, or even from legislative restrictions to certain types of drugs. And the last one being 59% of Americans feel comfortable ordering controlled substances through a telehealth provider, which is great because there are a lot of good telehealth providers out there as well. So next slide of slides, just setting the tone for where we are. Public comfort is not the same as public awareness. Many Americans lack critical understanding of their risks, and many do not distinguish between legitimate and illegitimate sources. And so what we see here is nearly half Americans would be open to purchasing prescription medications from an online source not sanctioned by the FDA. if it increased their access and decreased their costs. We know that 2 reasons folks go online for medications is because of convenience and for cost savings. And so that's what that first stat says. And then 1 in 4 Americans say they would accept higher risk when purchasing from online pharmacy if it meant increased convenience and savings in return. So that means that they rather they weigh those 2 factors, cost savings and convenience, higher than their own safety. And the last statistic I'll mention here is nearly half mistakenly believe that all online pharmacies are FDA or state approved. And so with that setting of the table, I'm going to kick it off to my colleague Elliot to talk about the actual policies that are on the table and how the current political environment may either move it along and what's the political appetite to advance any of this.
Thanks, Nisha. And want to remind folks, if you do have questions, feel free to pop them in the Q&A, and we will either answer them at the end or as we go throughout the presentation. We do have one already inquiring about the administration's position on PMPs as a tool of combating prescription fraud and fake online pharmacies. The truth of the matter is, I think that's a likely position, that they do see prescription monitoring programs in the same way they did when President Trump was in his first term, that those are an effective tool by states. I think the question is, what level of funding will they get? And we really don't know that. That's going to be a decision for Congress, but this at least atmosphere leads many of us to believe that there's going to be significant cuts across the board, and that potentially states are going to have to fill that gap moving forward. But it really is too early to tell. Congress is working on fiscal year 2026 appropriations currently, and I think we're going to see some of this play out. The other thing I'd note is in conversations with the DEA is that they're actually seeing quite a bit of an increase in electronic prescribing of controlled substances fraud. And so in addition to the industry stakeholders throughout the pharmacy supply chain, they view, I think, PMPs as a means of potentially helping address that challenge, right? So with the number of healthcare breaches that have taken place over the last couple of years, what's actually happening is there are people who are stealing entire profiles of DEA registrants to issue essentially large numbers of prescriptions in very short periods of time, so that those prescriptions can be filled and potentially diverted by either online pharmacies or in-person pharmacies. So it's an ongoing thing that they're looking at, but to your point, I think the prescription monitoring programs are going to continue to be a priority for the administration. The question is to what level and whether they're going to put money where their mouth is on it. Right. Let's go ahead and talk a little bit about the Ryan Haight Act. I'm sure many of you are familiar with this, but it went into law in 2008, and it gives DEA the authority to regulate online pharmacies. Controlled substances may not be dispensed via the internet with the exception for legitimate telemedicine purposes. And what it essentially said was that you have to see a patient in person prior to prescribing via telemedicine. So the DEA was also required through that process to create a special registration process. Again, this was back in 2008. Well, as many of you know, that has not happened yet. That special registration process still, which is statutorily mandated, has not been created. However, DEA over the past several years has worked to address that. So I just want to walk through the timeline of the regulatory environment because I think it's helpful perspective. And I'll even start before this first box here, which is to say that in 2008, Ryan Haight went into effect. DEA was told to create this regulation. They did not do so. In 2017, when the Support Act passed, which was intended to address the opioid crisis and substance abuse treatment, they were actually mandated again by Congress to promulgate this rulemaking and still didn't do it, which brings us to 2020, the COVID-19 pandemic occurring. And the administration, the Trump administration, putting in place a flexibility for the prescribing of controlled substance that allowed Schedule 2 through 5 controlled substances to be prescribed without an in-person visit via telemedicine. It was a significant change in administration policy. And as you can see, this has been extended several times and is currently still in place today. The administration, the Biden administration, basically over the last 2 to 3 years, had begun the process of creating a special registration for telemedicine, and we will talk a little bit about that process momentarily. But basically, we're in a position where the current extension remains in place until December 31, 2025. And again, that means that prescribers who are DEA registrants of controlled substances, nurse practitioners, physician assistants, and physicians can prescribe controlled substances via telemedicine without seeing a patient in person, period. And that's Schedules 2 through 5. So, as I mentioned, the Biden administration announced in the spring of 2024 that they intended to create this special registration for telemedicine. It was going to be a proposed rule, and you can look back through this timeline towards the bottom, and what you'll see is that they started this process through temporary rulemaking in 2023, and it continued all the way into 2024 when they finally plan to release this proposed rulemaking. And in the summer last year, they sent a notice of proposed rulemaking to the White House, the Biden White House, for review. And I think everyone was very hopeful that that rulemaking would get released quickly. But as you can see, that rulemaking, which was a proposed rule with comment period, did not get released until January of this year, 3 days before President Biden left office. Now, let's talk a little bit about this. So, the special registration for telemedicine rulemaking came out, and it was accompanied by 2 final rules, one addressing the prescribing of buprenorphine, and another addressing continuity of care via telemedicine for patients in the Department of Veterans Affairs. So 2 final rules and 1 proposed rule. The proposed rule will have would have a comment period, and let's talk a little bit about that. So the special registration for telemedicine rule had a 60-day comment period. It was a proposed rule. That comment period ended in March, on March 18th. And the current administration is sitting on those comments. What it did was establish a special registration framework that authorized 3 types of special registration for telemedicine. One was for a standard sort of special registration, Schedules 3 through 5. And then it had a advanced telemedicine prescribing registration for Schedule 2 through 5, and that's for specialized practitioner. What does that mean? It means physicians who have specialized training in things like mental health disorders. So what they were trying to do was preclude essentially nurse practitioners and others who were not trained in specific mental health conditions from prescribing things like stimulants and other Schedule 2 substances over telemedicine in significant volume. There was also a third piece of this, which was actually unique, and I think some people were of questionable legality, but they created registration for telemedicine platforms. So the Ryan Haight Act obviously did govern online prescribing and online pharmacies, but not necessarily under that statute did DEA have authority to regulate telemedicine platforms, but they were going to offer the opportunity for a registration to telemedicine platforms through this process. It also had a number of prescription record keeping and reporting requirements, which were designed to give DEA more data and transparency into the supply chain so that they could better regulate the providers as well as the dispensing and the prescribing throughout. So again, DEA stated their goal was to expand patient access to controlled substance medications via telemedicine while mitigating the risks of diversion associated with it. And that's a very difficult line to walk. Now, again, this has not gone into effect, and DEA really is sort of in a difficult position. And so we'll talk about the long-term implications of this in a moment. The final rule that addressed buprenorphine treatment was set to take effect on February 16th. And I will hold off on telling you later whether it actually did go into effect. But it expanded the circumstances for DEA registered practitioners to prescribe buprenorphine by allowing audio-only telehealth initiation of MOUD. That was a very big deal. The prescriber had to review PD&P data in the patient's state, and they could prescribe up to a 6-month supply of MOUD as well. So significant development here, and it essentially created more lax rules for the prescribing of buprenorphine as compared to the rest of controlled substances that could potentially be prescribed under the special registration for telemedicine. Now, uniquely, this provision, this final rule, would not go into effect until the special registration for telemedicine was finalized. So it was designed to work in tandem with the special registration for telemedicine process. The third rule was a final rule related to the Department of Veterans Affairs. As many of you know, the Department of Veterans Affairs across licensing and other areas of care is able to preempt state law to allow their providers to practice across state lines through telemedicine, also allowing them to practice in person with only one license if they're visiting a patient at another facility that may be across a state line as well. So the VA has great authority, and this particular rule leaned into that legal authority by authorizing VA employed practitioners to prescribe controlled substances via telemedicine without having evaluated a patient in person, as long as any other VA practitioner has previously seen the patient in person. So you can imagine a scenario where specialists in one location may not have seen a VA patient, but they are seeking care at a VA facility and have been evaluated in person before in the VA. That person can be prescribed a controlled substance under this authority by that specialist, even though they've not seen the patient in person. So public health implications play a big role in how DEA has viewed this. And just to rewind a little bit back to the Biden administration, when all of these three rules were being perceived, or as they were drafting all of these, there was a lot of contention about what the most important public health priorities would be. And so DEA, frankly, was at odds, and this has been chronicled through the media over the last year, with folks across other federal agencies, namely SAMHSA and HHS, about how to balance access to controlled substance prescribing via telemedicine while also keeping public protections in place. And so those debates really are what delayed the release of the proposed rule and the two final rules that accompanied them until January, after the election, after the administration knew they were leaving office, sort of forcing the hand of the Trump administration to actually deal with all three of these issues when they came into office. So, but what are the public health implications that now the DEA has to look at as they're looking at these issues moving forward? So I want to just give some insight into what they're seeing. They're watching increasing stimulant prescribing. So it continues at elevated rates post-COVID. As many of you know, from 2012 to 23, dispensing of stimulants increased by 60%. There's been a significant increase in these prescriptions by nurse practitioners, which has been chronicled by IQVIA. Most of this data on here, by the way, is from IQVIA. And in 2023, 21% of stimulant prescriptions were co-prescribed with another controlled substance. And over half of that 21% were either benzodiazepines or SSRIs. Having talked to some pharmacists, they're not super surprised by this, but what DEA has said about stimulant prescribing is that they're seeing same trend lines that they saw with the opioid crisis. So while the same level of risk may not be there, they are concerned about stimulant prescribing. Now, what's happened in the last year or so is that the prescribing levels have leveled and not continued on their sort of previous incline that they saw during the COVID-19 pandemic. So I think that's going to figure into their calculations in terms of how they're going to proceed on this policy issue moving forward. They've also continued to seek an increase in access to buprenorphine. That's a big policy priority for them. And the total number of patients who are seeking treatment, MOUD treatment, has really stabilized. The number of NPMPA prescribers has increased 9 to 12 times. So that is largely due to the removal of DEA's X waiver, which some of you may remember happened last year or the year before. Because of that, and the focus by some very specific companies to increase access via telemedicine to those populations, they're largely using nurse practitioners and PAs to be able to do that, those non-physician prescribers. And a big thing that people are, that DEA is still hearing is that MOUD prescribers and the pharmacies that are dispensing buprenorphine are still concerned about potential DEA scrutiny or prosecution because of high prescribing and dispensing rates of those drugs. DEA over the last couple of years has worked hard to sort of dispel that and say, hey, we're not coming after you for this, but it is nonetheless a concern that they continue to have to address. And then finally, the rise of ketamine. Off-label ketamine and esketamine prescribing continues to climb. It's a therapy for some really difficult to treat mental health issues. And from 28 to 2023, dispensing of ketamine prescriptions increased by 350%. They've also seen an increase of telehealth platforms claiming to do remote monitoring of ketamine administration for off-label purposes. And this is one of those areas where there's not a lot of clinical protocols or suggested means of sort of treating these mental health disorders. And so that gives DEA some concern as well. So we've talked a little bit about the rulemaking. We've talked what DEA is looking at and historically looked at, but what about the politics of this? When will the potential proposed rule result in a final rule, and potentially could these other two rules go into effect? I think I've just spoiled the punchline here, but rule implementation has been delayed. So in March, DEA and HHS delayed implementation of both the buprenorphine rule and the VA rule until the end of this year. That's a very significant deadline because now the existing waiver of Ryan Hydak's in-person visit requirement for telemedicine prescribing and the implementation of these rules all are synchronized at the end of this year. So if the administration, if DEA and HHS do nothing, we will go back to the pre-COVID-19 policy that a patient must be seen in person and before being able to be prescribed controlled substance via telemedicine. That's what would happen if DEA and HHS did nothing. Now, I think a lot of people are confident that there will be some form of a regulatory extension that happens. But guess what? Because there's no permanent special registration for telemedicine rulemaking in place, and DEA has not, I'm sorry, the Senate has not confirmed a DEA commissioner. What we actually are experiencing here is a likelihood that there will be no permanent rulemaking for special registration by the end of the year, nor could it potentially even be implemented because that's 6 months from now. So we're likely going to see another temporary extension at some point. And that may be a exact replica of what we have now with Schedule 2 through 5, but a number of political appointees have signaled an interest in removing Schedule 2 drugs from this temporary waiver. So we will see what the administration decides. Congress could also have a say on this at some point if they decided to do that. So a few other issues. What's next that people are looking at in this space? First, geographic red flags. I'm sure some of you are familiar with this. These were a hot topic during the multi-district litigation during the opioid crisis. So red flags are designed to signal to pharmacists that a prescription may be illegitimate in some way and to view it with suspicion. The DEA has stated that pharmacies may not dispense prescriptions that have been flagged unless additional steps are taken to ensure the validity of the prescription. This goes along with pharmacists consistently being told they need to perform their corresponding responsibility when dispensing controlled medications. Geography and distance continue to be a red flag, and what we have even seen this up through last year, that when DEA is listing decisions in certain cases that they've brought against practitioners, that they continue to view geography and distance as a red flag. These are not explicitly laid out in some sort of DEA document, but rather they are ascertained again through the DEA's judgments that show up on the Federal Register when they're taking action against pharmacies and pharmacists. Injunctive relief requires distributors to consider out-of-area patients as a red flag, and this is exactly what we were talking about. So distributors are to consider prescribers that represent a significant volume of dispensing where the prescriber's practice location exceeds 50 miles from the pharmacy compared to the percent of non-controlled substance prescriptions. So an interesting policy we wanted to flag because I think this is an unresolved issue at DEA. They are going to have to be clear about how they will address this issue if or when they decide they want to pursue a special registration for telemedicine. And with that, I will move on. Nisha, I don't know if you have any additional points that you'd like to make, or we can move on to some questions.
Just as a quick note, I can read the questions, but the participants on the webinar can't see the questions. So if we're doing Q&A, we need to read the question and then give the answer as well.
Okay, and why don't I go ahead and stop sharing so that folks can see us. And yeah, so I'm happy to sort of take this second question. How does the use of buprenorphine for pain management affect protocols for its use in substance use disorder? That's a good question. I don't have a good answer for this, but I know that DEA has, in fact, attempted to look at the varying uses of buprenorphine and be considerate of all of those factors when they're looking at prescribing. And I'll just say, like, a couple of years ago, there were some factions within DEA that had intimated that there was diversion of buprenorphine for various other reasons, right? And over the last 2 years, they've kind of quashed that and really focused on making buprenorphine access a sort of universal right, if you will, or a universal policy belief. And I don't have a good answer in terms of like how the protocols are for that, but that's just sort of my perspective, knowing how DEA looks at this.
I'm happy to talk through one question that was asked and then the answer in case it's not visible to everyone. But we did get a question about the following. I'm having difficulty understanding the strategic planning around the transition from the current structure to this new streamlined structure that allows for an immediate 50% reduction in the HHS budget. Does administration expect vital services to end abruptly? It seems inevitable, but I don't see how or if this has been accounted for in the government's plan. So I responded back to that individual, but I'm happy to share it here. But generally, as I shared previously, there's a strong motivation from this administration to reduce the national deficit. And given that HHS represents a significant portion of the federal spending, it becomes a key target for cuts. While there are many programs within HHS that could potentially be reduced without affecting core priorities, what we are seeing so far appears to be more broad sweeping cuts rather than more strategic targeted reductions, which is definitely where most stakeholders are. I think you're right to the extent that, yes, we have kind of conflict of policy, which is a trend and pattern we saw in Trump 1.0, where we have a lot of support for SUD treatment, a lot of support for recovery. But then when it comes to the actual numbers, we see a reduction, which kind of begs the question, how do you do one without the other? And that's something that's going to be the devil in the details. As I said, the budget, this president's budget was released a month ago, and we're just seeing HHS just last week come in with what their justifications is and how they plan on meeting those new numbers. I think to be seen. I do think that it's being accounted for, just rather if there's will to continue to fund programs at their previous levels. And we're seeing a little bit less of a motivation to do so.
Perfect. And then we have, kind of following up on that question, we have a question that says, do you have any insight into the continued funding for the CDC overdose data to action and states cooperative agreement? This is supposed to be a 5-year agreement with annual renewals through August 31st, 2028. We were advised by our grant manager that other CDC grant renewal awards have either come later than expected or not at all. Are all of those funds already allocated for future years from the original award, or do they need federal reauthorization for each federal fiscal year? What is the likelihood that the awards could be discontinued early, or that CDC could cut certain portions of the awards, such as grant-funded employees?
I don't know, Elliot, if you had a reaction. I would say we are seeing grants that have been authorized and appropriated be cut. So that's my short answer. It's not unheard of. Certain buzzwords and certain grants have been deemed as, not aligned with administration, not aligned with the mission of certain agencies. So I personally don't have specific information about this grant, so I don't want to say that it's going to be cut without actually having heard that. But is it a possibility? Sure. But I don't know, Ellie, if you feel like there's additional information,
Yeah, so this is a challenging thing because there's two answers. One is some of these grants are delayed because they've gone under review and the administration is deciding whether they want to continue them. They are if the money has been appropriated by Congress, they are statutorily obligated to disperse it under congressional authority. However, one thing that's happening right now is that the administration is sending what's called rescission packages to the Hill. And Republicans can essentially vote to give the administration the authority to not disperse funds for things like grants who've already gone out and pull that money back into the federal treasury. They're going to say, this is not a priority anymore. We're not going to administer these programs for X, Y, and Z reasons. But it requires an act of Congress to essentially undo the thing that the previous Congress did. It's just from a precedent standpoint, it is not great that any one Congress can overrule another Congress when you're spending money like this. So that's not like a great thing. The thing is, I don't think we've seen this current rescission package that came down this week or last week. I don't believe includes a number of CDC provisions. It's other programs. So TBD, I think. But if you have a 5-year grant and you're still in that cycle, theoretically, at some point, they will have to disperse those funds.
And I will say that there is still a lot of interest in the congressional level and support, bipartisan, bicameral support for a lot of these issues, including PMPs. We did hear that from Hal Rogers's staff earlier maybe one or 2 months ago at a conference. So I think you still have those same champions beating the drum. It's just a rather of back to kind of the way that the power is being wielded, a very top-down approach, which one wins out. And right now we're seeing really the administration winning out on a lot of its priorities being streamlined down. So a related question to PDMPs, any movement on a national PDMP that has been mentioned in some draft legislation? It doesn't seem to move anywhere, but could it? I'll say a short answer, then we'll welcome Elliot to give even a longer answer. I would say a national PDMP is very challenging to even consider in an environment where we're in an administration that is definitely more looking to decentralize powers rather than centralize powers. So I don't see a national PDMP. This is not the political environment where that has much appetite. I think giving states the ability to control their PDMPs is much more in line with what the administration would want to do. So I don't think there's a national PDMP appetite even before, and I think that has even become slimmer in this environment.
Totally agree.
Perfect. There's one more question, but have you heard anything on whether the DEA or FDA is looking at scheduling kratom? It's been of concern in several states, and we've had several NASCSA webinar topics on kratom itself.
That's a good question. So first, I would say I've heard more conversation about states adding it to their lists, their controlled substance list, but I have not heard DEA necessarily talk about that. There is a process, as I'm sure many of you know, for DEA potentially exploring this, but it's really hard to say what DEA's priorities are on things like this when they don't have an administrator. And so I think it's going to take some time to see what Administrator Cole's priorities are on issues like this, because most of what he has talked about is addressing, the fentanyl epidemic, enforcement at the border, and things of that nature. And I don't mean to dive off the topic, right? Like, this is an important conversation that I know a number of states reckoned with as state legislatures have come to the end this year, but it's not one that has really made it to the national landscape. People out here are still talking about fentanyl, xylazine. DEA is still talking about those issues and the importance of addressing those challenges. Now, just generally with the scheduling of anything, it gets really challenging. There's only two things that have really nationally been talked about, and that's the rescheduling of marijuana to Schedule 3. And then Congress voted to make fentanyl a Schedule 1 controlled substance and keep it there. They've done some exemptions for hospital use and, of course, for research, but they have increased the criminal penalties associated with that to Schedule 1. So those are the two big rescheduling items that we have heard Congress and the DEA talk about.
I'll just say something really quick. I know kratom was on the table back in 2016, 2017. There was a back and forth between what DEA wanted. I think then HHS gave recommendations, and then there was a little bit of a whiplash. We haven't heard that conversation again. Not to say it can't come up again. That's kind of what my tone is on kratom. I haven't heard it creeping up, but that's just to say that we're only 4 months in. Maybe once the DA administrator is picked, maybe that might come propping up a little bit later on in the year.
Mhm.
Perfect. Well, thank you guys, Nisha and Elliot. Thanks for doing the webinar for us today. This has been fantastic. We've gotten a lot of positive feedback in the chat. So on behalf of NASCSA, I would like to thank everyone who joined today's webinar. Thank you to our sponsors for making today's webinar possible. And we wish you guys a wonderful rest of your day.
Thank you.